Well, there are many new data that have been presented. We have seen data with a combination of immunotherapy with chemotherapy in the metastatic settings, the Empower Lung 3 study. We also have seen some negative studies, such as the Contact-01 with a combination of atezo plus cabozantinib versus docetaxel. So it brings additional data, and it helps to think about the current strategies that we are developing for our own patients, but also thinking about the new developments and how to best individualize immunotherapy for these patients. Well, nivolumab plus chemotherapy in the neoadjuvant setting for resectable non-small cell lung cancer is approved in several countries now. It has become a standard of care after the presentation and the publication of the primary analysis of event-free survival and pathological complete response. Now we have the 3-year update, and it clearly shows that we have a continued benefit with the combination of nivolumab to neoadjuvant chemotherapy in those patients with resectable disease. We can see that the hazard ratio is remaining pretty similar. This is almost a 40% decrease in the risk of disease progression after neoadjuvant treatment and surgery. We also have updated overall survival data, further strengthening the value of this combination, while it is not yet sufficiently mature to have a statistical significance. And at the end, we are now able to better understand what are the recurrence patterns for these patients. And interestingly, we showed that with the addition of nivolumab to chemotherapy on these 3 cycles, we can protect those patients from developing CNS disease along with the follow-up. Well, it's very interesting to try to better stratify the patients, and one easy way to do that is to look at PD-L1 status. And it's becoming more and more clear that for patients with a PD-L1 negative tumor, you can do a combination of chemotherapy plus anti-PD-1 agent, but maybe it's not sufficient to provide the patient with a significant, clinically meaningful long-term survival. With dual immunotherapy, with or without chemotherapy, I have to say that the PFS values, the OS long-term is probably higher, especially in those patients with a PD-L1 negative tumor. With the combination of 2 immune checkpoint inhibitors, the predictive value of PD-L1 expression for long-term survival is less correlated with this expression. So at the end, with dual immunotherapy, maybe we will have better outcomes long-term as compared to patients currently receiving a combination of chemotherapy plus immunotherapy. Within this subset, we have patients with common EGFR mutations, the most frequent, but we also have uncommon mutations, including the EGFR exon 20 insertion mutations. In those patients, we have targeted agents that are available in the second-line setting, including amivantamab, which is a bispecific antibody, and mobocertinib, which is a TKI. So this is obviously very interesting to have targeted agents for these patients. Now we are treating the patients in the second-line setting after the failure of chemotherapy, but there are ongoing trials assessing these agents in the first-line setting. So at the end, it's very important. The first step is actually to identify those patients, and this is done through next-generation sequencing, which is recommended in the ESMO clinical practice guidelines for all newly diagnosed patients with metastatic lung cancer. Another challenge for these patients is to understand what is the best sequencing of treatment, what are the resistance mechanisms. There are many new agents that are under ongoing evaluation. So this is a very interesting field. These patients are maybe never smokers, maybe smokers, but at the end we miss opportunities to develop truly efficient strategy for this patient. So there are promising data. We have seen during the ELCC meeting the updated results of the Chrysalis trial assessing amivantamab in the late line setting. Very interesting to see that we have a significant proportion of patients who are receiving the drug for more than 2 years. Very interesting to see that 1/3 of the alive patients at 2 years are still without disease progression. So we see that in the clinic, and the management of these patients is really important.